Good evening, everyone. Thank you for joining tonight's presentation of No Ifs and or Buts. You need a colorectal screening presented by the Newton-Wellesley Hospital Multidisciplinary Colorectal Oncology Team. My name is Monique Porter, and I recently was the Director of Oncology Services for Newton-Wellesley Hospital and the Mass General Cancer Center at Newton-Wellesley. March is Colorectal Cancer Awareness Month. Colorectal cancer is the third most common cancer diagnosed in both men and women in the United States. A colorectal screening is essential and potentially life-saving. Tonight, you will learn about new trends in screening, which modality is best for you, and treatment options. Please feel free to type any questions you may have in the Q&A feature anytime during the presentations. It's now my pleasure to introduce tonight's presenters. Dr. Lawrence Bailon is a medical director of the Mass General Cancer Center at Newton-Wellesley Hospital and chief of hematology and oncology. He also serves as the chair of the Cancer Care Committee. His mission is to deliver high-quality, multidisciplinary oncology care to the community and to foster relationships between the Mass General Cancer Center in Boston and the community. Dr. Lawrence Bailon is the acting chief of gastroenterology and medical director of the GI endoscopy unit at Newton-Wellesley Hospital. He is also a clinical associate professor of medicine at the Tufts University School of Medicine. Dr. Todd Francone is currently on staff at both Mass General Hospital and Newton-Wellesley Hospital. At Newton-Wellesley, he serves as the chief of colon and rectal surgery, associate chair of surgery, and director of the robotics program. His expertise also includes advanced minimally invasive surgery, performing over 600 robotic colorectal procedures, in addition to thousands of single-port and multi-port laparoscopic procedures. Dr. Ted Hong is the director of gastrointestinal radiation oncology at Mass General Hospital and professor of radiation oncology at Harvard Medical School. His research interests are multidisciplinary therapies for gastrointestinal cancers, proton therapy, biomarkers of response, and combinations with targeted and immunotherapies. I'll now turn it over to Dr. Bailon for the first presentation.
Thank you, Monique. Let me see if I could get my screen up here. Are you guys seeing it okay? Can't tell what you're seeing. All right.
Dr. Plaskowski, if you'd please put it into the presenter mode, that would be appreciated.
Presenter mode. I put it in. So not sharing?
Go to display settings.
Go to display settings.
Okay.
Yep, press that. And then duplicate slideshow.
Yeah.
Press that. There you go.
You okay? All right.
I learned that from Lawrence.
All right. Well, I'm the last to learn. I don't know which screen to look at. Here we go. All right. Well, welcome everybody. I'm Larry Blaskowski, and I'm a medical oncologist, and I'm going to start us off today. This is our agenda. I'm going to give a discussion about epidemiology and overview, and then Dr. Bailon is going to talk about colon cancer screening, and then Dr. Francone is going to take over and talk about surgical approaches to colorectal cancer, and we're going to finish with Dr. Hong talking about rectal cancer and the role of chemotherapy and radiation. So this comes from a really great publication that comes out every year from the American Cancer Society. It's available to anybody. You don't need a subscription. And every year they project out the cancer statistics for that year. And it's really interesting. They break it down by site of origin, by state, and they talk about different groups and different risk factors. So I encourage anybody who's interested in this to look that up online. But this is a slide I always like to start off when I'm talking about one of our GI cancers, to show you that of the 10 most common cancers in men and women, colorectal cancer ranks as the third most common in new cases. And when you look at deaths, same thing, third most common. If you combine men and women incidence, it's actually the fourth leading cause of cancer, and it's the second leading cause of cancer-related deaths. Now, as you can see here, the overall incidence of cancer had gradually increased from 1975, reaching a peak in the early 1990s, and then a steady decrease over time. This peak here in male incidence is probably mostly due to use of PSA screening for prostate cancer. And then after we found that we were diagnosing many very early stage prostate cancers, patients who probably didn't even need to have intervention. So over the years, there were new recommendations to back off on how aggressive we were with PSA screening. And that's part of the reason why there's been a decrease in incidence, but there's a decrease in incidence also because of changes in behavior, such as a reduction in smoking, which I'll mention probably several times tonight, and improvement in screening over time. In females, there's still been a gradual increase, although that's leveling off, and that is primarily due to a continued increase in breast cancer. But in mortality, in death from cancer, we've really done very well, in that there's been a substantial reduction in men and women, especially since the 1990s. This year, we expect to have nearly 2 million new cases of cancer diagnosed in the United States, and nearly 610 deaths due to cancer. When we talk about colon cancer, there'll probably be about 150,000 new cases, and that's been gradually decreasing, 106,000 of which will be due to colon cancer, and about 45,000 due to rectal cancer. And in terms of US deaths due to colorectal cancer, just over 50,000 are expected this year. In Massachusetts, just under 3,000 new cases, and just about 1,000 deaths expected due to colorectal cancer. And in terms of non-Hispanic Blacks, they actually have a lower death rate than non-Hispanic whites in Massachusetts, and that's very different than most of the states, where the death rate is typically higher for Blacks than whites. Internationally, this tells us that there'll be about 19 million, or was 19 million, new cancer diagnoses in 2020, and 10 million deaths due to cancer in the world. Internationally, there'll be about 1.9 million new cases of colorectal cancer, and just under 1 million deaths due to colon cancer in 2020. Now, in this slide, if you look at the top, this is looking at males on the top and females, excuse me, on the bottom. And on the left side is the incidence, the new cases in countries with a high HDI, which is the Human Development Index from the UN. And you can see that in colorectal cancer, it is the third leading cause of cancer in men, and in women, it is the second leading cause of cancer, at least in the high HDI countries. Basically, these are countries that have great access to healthcare, fairly wealthy countries, developed countries. And in the low, medium HDI countries, in men and women, there's a lower incidence of colorectal cancer. Now, looking at region or countries for colon cancer, you can see that I circled the United States, or North America at least, because our Canadian friends are very similar to us. And we are about the 6th in terms of the leading cause of cancer. And then if you look down at rectal, we're about the same in terms of number 5 of rectal cancer. Now, trends in terms of the incidence by sex in the United States, you can see for men, Prostate, I mentioned before, this increase in the early mid-1990s was primarily due to prostate cancer because there was a marked decrease in lung cancer, a decrease in colon cancer during that time. There has been a gradual increase in breast cancer, and that's probably, and you can see that right here in this purple line, due to declines in fertility and increase in body mass index, so increased weight. But, fortunately, as I mentioned, there's been declines in some other very common cancers, as well as in non-Hodgkin's lymphoma, melanoma, and in liver cancer. Liver cancer, we've been worried for many years due to the increasing incidence of cirrhosis due to hepatitis C. But now we have great treatments for hepatitis C, and is expected that the incidence of liver cancer will decline over time. Now, despite the fact that we're really happy to see this decline in colorectal cancer, this is really seen in those aged over 55. Unfortunately, there's an increase in incidence in those who are less than 56 years old. Now, cancer in general, the 5-year relative survival rate has increased from 49% to 68%, and 50% to 63% in Blacks. When you compare the mid-1970s, so right around here, to the interval between 2011 and 2017, right here. So that's obviously a huge win, and there are many reasons for that, including improvement in screening. So we're diagnosing, we may be diagnosing more people, but we're diagnosing cancer early. Prevention, so that's due to changes in diet, increased screening, as I mentioned, for colorectal cancer, which Dr. Bailon will talk about. But really the big thing is a decrease in smoking, and there are so many cancers that are impacted by smoking. So I think the biggest thing that we've accomplished here in the United States is a reduction in smoking. And the reason why some of, especially in lung cancer and some other cancers, the incidence and mortality from cancers has been slower to improve in women is that they were slower to decrease smoking. And can't forget that we have a lot of new treatments, and we've, so our treatment has improved, the use of adjuvant therapy, so giving chemotherapy and other treatments after removal of the cancer. So a lot to be happy about in terms of how we've improved in cancer. And with these improvements, we've actually averted 3.5 million deaths due to cancer since 1991. If we didn't have any of these improvements and we didn't have modifications in lifestyle, smoking cessation, this red line would be where our mortality would be from cancer in men and women. So, this is something that we hopefully will continue to see. Getting back to the increased incidence in colon cancer in those less than 55, we've seen a 51% increase in colorectal cancer in those less than 50 between 1994 and 2014. Between 2014 and 2018, there's been a decline of 2% per year in those who are over age 50, but an increase of 1.5% per year in those who are less than 50. The rectal cancer incidence rate has doubled. So we've seen a higher increase in the rectal cancer population between 1991 and 2014. When we talk about deaths due to colorectal cancer, that's decreased by 2% per year between 2010 and 2019. But between 2005 and 2019, it's risen by 1.2% per year in those younger than 50, and by 0.6% per year in those aged 50 to 54. In fact, in adults born around 1990, they'll have a 2 times higher risk of developing colon cancer and a 4 times higher risk of developing rectal cancer compared to those who were born in 1950, which was the lowest incidence year. A lot of nice colors on this slide, but really what I want to point out is that if you look at the age 50 to 54 year group, this is where you start to see an increase in incidence. All the other ages, a gradual decrease in incidence over time. On this axis is the year of birth. So if you look straight down from here where you see the increased incidence, it really applies to those who were born around 1950. So something happened around 1950. And since then, that we've seen in every age group below 50 to 54 years old, where there's been an increase in incidence. And this is basically says it in a different way. Looking at the international trends, here on the top, these are all the countries, or these are countries where there's been a decrease or stable incidence in those greater than 50 years old. And I circled the United States right here. There's been a 2.4% reduction per year over 10 years. And then if you look at the age 20 to 49 age group, we have this increase of 2.2% per year annualized over 10 years. Countries that have a higher incidence than us in this age group include New Zealand, the UK, and Canada. On the bottom are countries where has not been a decrease in the age over 50, and there's been an increase. And many of those countries have the same problem of an increasing incidence in the younger population as well. In places like Korea, for example, there's been more wheat introduced into their diet, a more Western diet over time. And there's been a fair amount of increase in BMI in Korea, which may explain the overall increase both in age over 50 and lower. So how do people with colorectal cancer present? Well, many of them present with no symptoms. And hopefully the majority present with no symptoms because they're being diagnosed on a screening colonoscopy and hopefully at an early stage. But when not diagnosed at a screening colonoscopy, they may notice an alteration in their bowel habits, oftentimes constipation, change in frequency, change in stool caliber. Stool may be looking thinner, which is seen in tumors mostly in the left side of the colon and rectum. Rectal bleeding. Rectal bleeding is seen more commonly in rectal cancer and left-sided colon cancers. If you have a cancer on the right side of the colon and you're having a little bit of bleeding, by the time the stool is kind of liquid on the right side, so by the time that stool gets to the rectum, that whatever blood is there might be mixed in with the stool and you may not be able to see it. Sometimes we could feel a rectal mass on examination, rectal examination, or an abdominal mass on examination of the belly. Many people present with anemia. So it might be you go for your routine exam with your primary care doctor or nurse practitioner, and the blood count comes back showing that you are anemic and your iron is low. Well, the first thing that practitioner is thinking about is there a colon cancer or a cancer in the GI tract and patients losing blood? Abdominal pain. Well, we all have pain for various reasons, but typically pain that persists. Pneumaturia is a term for air in your urine. So sometimes people may urinate and they notice that there's gas. And that's due to tumor that's growing into the bladder from the adjacent bowel. Sometimes people could present with an infection in their blood. And these are just some organisms that are commonly associated with that. And that's because the tumor grows through the wall of the bowel and then the bacteria finds its way into the bloodstream. And weight loss, that's true for many cancers. People may just lose weight over time. And sometimes these cancers, especially on the right side of the colon, there can be very little symptoms related to that. They can get really big and spread to other parts of the body, and that's when you will lose weight. So the general workup, a colonoscopy, if we're suspecting that there might be a colon cancer, but many of the patients, we already know that they have a colon cancer from the colonoscopy. And we typically would start with a scan, and that's a CAT scan, a CT scan that includes the lung, the abdomen, and the pelvis. And that's because this cancer can spread most commonly to the liver, also likes to go to the lung, the belly cavity, less commonly to the bone, and very uncommon to the brain. So we don't typically look at the brain when we're doing what we call staging for the colon cancer, colorectal cancer. An MRI can be very helpful if we see something that we're worried about in the liver on the CT scan, and is very important as part of what we call the staging for rectal cancer. And it's our favorite modality or type of scan to get for rectal cancer. There are some times where we can't get an MRI, and in that case, we sometimes get an ultrasound of the rectum. There are blood tests that we usually get. One test we commonly get is called a CEA, or Carcinombrionic Antigen. And this is a protein that tumors secrete, and we can measure in the blood. It's not measuring the actual cancer, it's just measuring this protein. And not all colon cancers will produce it, but some do. Some produce a little and some produce a lot. And that's something that we typically check and something that we monitor, even if the cancer is removed over time, to try and detect a recurrence. And we check the blood counts, and we check the liver tests. PET scans are tests that we sometimes get. These are radioactive tests where you inject a radioactive sugar and the tumors can take it up. We only usually get this test if we're worried about cancer that spread somewhere else. How do we take care of colorectal cancer? Well, hopefully, we'll tell you that this can be cured with surgery, in which case Dr. Francone is your first stop after us. Sometimes, if the cancer is advanced, we may recommend doing chemotherapy up front. And as Dr. Hong will mention, we often do chemotherapy before rectal cancer. If the tumor is advanced, we'll do chemotherapy we might not have to do surgery. But if you have surgery and we find out after surgery that your lymph nodes had cancer in it, we will also talk to you about getting chemotherapy. Radiation is typically used for rectal cancer, but there are occasions where we use it in colon cancer and when the tumor spreads to other locations like liver. The interventional radiology team helps us with placing a device called a port, and that's used for chemotherapy and those people who need to get chemotherapy. And sometimes they help us to biopsy abnormalities that we might see on a CT scan or an MRI. Now, after you have your surgery, after the cancer is removed and any treatment is done, that doesn't mean you're done with the medical oncologist or the radiation oncologist or the surgeon or the gastroenterologist, because we need to monitor patients for recurrence or new cancers. And that may include doing blood tests periodically, doing scans, usually CT scans, as well as colonoscopy. And I'll leave this up to Dr. Bailon to discuss more. And then we also arrive at survivorship. So just because you made it through the treatment and the surgery, we want to make sure we use that as an opportunity for you to adopt good measures for your health. And that includes exercise, and includes also for patients with colorectal cancer, we tell them to eat tree nuts. That's right, tree nuts. A serving of tree nuts twice a week may reduce the risk of colorectal cancer recurrence. So, and one of the reasons why we keep seeing people in the long term is that there may be other studies that develop over time that tell us about other measures that may be helpful for reducing the risk of colon cancer recurrence or other cancer recurrence. And so having those visits give us the opportunity to share that information with our patient. So with that, I'm going to pass it on to Dr. Bailon to talk about screening and colonoscopy.
All right. Thank you very much, Dr. Blaskowski. And let me just pull up my slides. Can you see that okay? I hope. Not hearing that you can't, then I will move on. So thank you everybody for being here. It's great to have so many of you here, and I'm going to talk to you about how we screen for colon cancer. And so why is colorectal cancer screening important? And it's important because colorectal cancer is one of the only cancers that you can actually prevent with screening. So you can prevent and not just detect colon cancer with screening measures, and removing precancerous growths in the colon that I'll show you some pictures of later on, called polyps, can help reduce the risk of cancer. And so by screening, by removing polyps, we actually can prevent colon cancer before it starts. And this is one of the only cancers that we can actually do this. So just some anatomy and some definitions. The colon and the rectum form the large bowel or the large intestine. So you've heard Dr. Blaskowski talk about the right colon or left colon. The left colon mainly involves the sigmoid colon, descending colon, and rectum. And the right colon involves, it's called the cecum and ascending colon and part of the transverse colon. And then the ileum is the end of the small intestine that connects to the large intestine. And your appendix slides right off of the end of the cecum here. So where does colorectal cancer start? So colorectal cancer usually starts in a benign growth, a polyp, that arises from the innermost layer of the colon, which is called the mucosa. And so if you see this slide on the left, this picture on the left here, the polyps start out as small growths, abnormal growths of cells lining the mucosa, the inner lining of the colon. And as you'll hear me talk about a little bit later, polyps that are called adenomas, and these detected, the type of polyp is detected after we remove it and the pathologist looks at it under the microscope. Adenomas are the polyps that eventually can develop into a cancer. So this process, the polyps that develop, they'll grow larger and they'll start developing dysplasia, which are precancerous cells. And as the process goes on and the polyp grows, it can develop into a cancer. And the most common type of colon cancer is called an adenocarcinoma. And so if these cells spread below the mucosa, below that innermost layer into what's called the submucosa, then cancer is present and it can then grow and spread to other organs potentially. The benefit of colorectal cancer screening is that it takes advantage of this process, which takes years. So the process of going from normal tissue to a small polyp to then a cancer often can take 5 or even up to 10 years. So that allows us time to intervene, to stop this process by removing these adenomatous polyps before cancer develops. And that's the benefit, and that's what we do, and that's the purpose of colorectal cancer screening. So what about colon polyps? So a polyp is basically an abnormal growth of cells in the lining of the colon. Most polyps are completely harmless, and not all polyps turn into a cancer. However, all cancers start out as polyps. And it's hard to know for sure which polyp that we see when we do a colonoscopy is going to end up being a cancer. And so we generally will remove everything that we see so as to prevent any one of them from turning into a cancer. But most polyps do not cause any symptoms. And most people who have polyps don't know that they have them. And that's why regular screening is important. So there is a lot of power in prevention. So these are some pictures from a colonoscopy that show the different appearances of colon polyps. And on the left here, you see a fairly large polyp. And when I show you these pictures from a colonoscopy, everything when we do a colonoscopy is magnified about 10 times. So things look larger than they actually are once we remove them. But this is a fairly good sized polyp. It's called a sessile polyp, in that the morphology of it is such that it's on a broad base on the lining of the colon. And here's another type of sessile polyp. And this is normal appearing colon with normal blood vessels that line the wall of the colon. And these white areas are just the reflection of the light from the colonoscope, reflecting off of the lining of the mucosa of the colon. But here's another type of polyp, another type of sessile polyp here. And then this polyp is called a pedunculated polyp because it is on a stalk. So this tissue here is actually normal colon tissue, and the polyp is looks like the tip of a cauliflower or broccoli stalk. And this is where the adenoma, this is where the precancerous cells can arise from. But some polyps can be hard to see. So on the left, here's normal colon here, But then this is what's called a flat polyp. It's just very slightly raised off of the wall of the colon. And you can imagine if the clean out, the prep that one needs to take prior to a colonoscopy is not adequate, we sometimes cannot see these. We can miss these. So that's why the prep, which I'll talk about shortly, is important. And then some polyps hide behind some of the folds. So this is our colonoscope here in the colon, and it's looking back on itself. It's forming like a J, so we can look what's coming behind. And this is a polyp that is behind a fold in the colon. So sometimes these can be hard to see. So colonoscopy and polypectomy, removal of the polyps, is the key way that we prevent these polyps from developing into a colon cancer. Now, if you have a colonoscopy and polyps are removed, you may see the pathology report, and you'll see that there are several different types of polyps. One of the more common types of polyps is called a hyperplastic polyp. And this is basically defined by the pathologist when they look at the specimen under the microscope. These polyps in general are quite benign. These do not follow that progression from a polyp to a cancer. They typically do not have any cancer potential. An adenomatous polyp, or what you'll see called a sessile serrated polyps, these are polyps that have a cancer potential. And then there are polyps that are even greater risk that we worry about and will tend to bring patients back for another colonoscopy at a sooner interval than we would otherwise if the polyp is not only an adenoma, but is more than 1 centimeter or more in size, or has a villous microscopic appearance. So the pathologist may describe in the polyp microscopically, it has what's called a villous appearance, and that tends to be a polyp that we know may eventually turn into a cancer. And then certainly if there is high-grade dysplasia, so dysplasia of those precancerous cellular changes, and our pathologists grade them, low-grade or high-grade, if there's high-grade dysplasia, that's also a higher risk polyp. So you may see some of these terms in a pathology report. So how do we remove the polyps? So here are just some sequential pictures of the technique that we use for removal of polyps in the colon. So here's that polyp that I showed you before that's on a nice stalk. And this stalk has a good sized blood vessel in it because it's feeding this tissue at the tip of the stalk, the polypoid tissue. And so what we typically will do is put one of these metal clips on the base of the polyp here to help prevent it from bleeding after we remove it. And these clips are tiny. We pass them through our working channel of our colonoscope, and they will fall off eventually, and you'll pass them in the stool and you won't even know they're there. They're so small. But again, everything is magnified here about 10 times. And then we'll pass a snare device or a loop, looks like a lasso, around the polyp base and apply electrocautery to this wire, and it cauterizes the tissue and the polyp comes off. And this is what the base of the polyp would look like on removal. And then we take this polyp out through our scope and send it to the pathologist. And often we'll put more clips on the base of the polyp that will help prevent it from bleeding. And I'll address bleeding or complication issues in a moment. And I noticed there was a question in the Q&A about risk and somebody on a blood thinner, warfarin, and I'll talk about that in a little bit. Here's another polyp actually in the same patient. And this polyp is a flat or more sessile looking polyp here. And you can see it here, again, kind of subtle. And we take it off with a snare again, and it's cauterized. And this device is called a net, a Roth net, which allows us to take the polyp, grab it, and pull it out. And then this is our clip being applied to the polyp base to help prevent this larger polyp. This is a more than 1 centimeter polyp to help prevent that polyp from bleeding. And these are 2 clips on the base of the polyp to prevent subsequent bleeding from the polyp base. So this is a slide just showing who should undergo colorectal screening. So we want to identify patients who are at greater risk to potentially bring them in sooner than we would somebody who has no risk at all. So what are some of the risks of colorectal cancer? And Dr. Blaskowski, I think, alluded to a few, but there are hereditary or risks in one's medical history. Family history is probably the most important. And if you have a first-degree relative, meaning a parent or a sibling with colorectal cancer, your risk is often twice what somebody without that history is. If you have more than one relative, if you have two first-degree relatives, two siblings, your risk is 4 times greater, significantly greater. And if your relative was diagnosed at a young age, you have a greater risk. Patients who have Crohn's disease involving the colon or ulcerative colitis, inflammatory bowel disease, are also at greater risk for colorectal cancer. And people with diabetes also have a slightly increased risk. If you drink alcohol at more than 3 drinks a day, the risk is also greater, as is obesity, defined by a body mass index greater than 30. If you eat a lot of red meat or processed meat, that also raises your risk. And as Dr. Blaskowski alluded to, cigarette smoking is definitely a risk, and for not just colon cancer, but for many cancers. Ways that you can decrease risk: physical activity. If you are more active, if your dairy consumption is around 400 grams a day, or milk consumption, these have been associated with a reduced risk of colorectal cancer. So who should undergo colorectal screening? So as many of you may know, our recommendations in patients who are considered to be average risk for colon cancer was to start colorectal cancer screening at the age of 50, regardless of any other risk factors. But recently, in the last 2 years, the American Cancer Society, the U.S. Preventative Services Task Force, and the U.S. GI Multi-Society guidelines have all recommended that we start colorectal cancer screening in people at average risk at age 45. And this follows some of the data that Dr. Blaskowski showed you about the rising incidence of colon cancer in people who are younger than 50. And we're seeing that anecdotally, and we're also seeing that in the data. So these are the new recommendations, and we're saying 45 is now the new 50 for colorectal cancer screening. People at moderate risk, Black individuals, have historically had an increased risk for colorectal cancer, and historically we always started or recommended screening at age 45. And then people with a family history of colorectal cancer or family history of colorectal advanced adenoma. And this table just dives a little bit deeper into what the recommendations are for people who have a family history of colorectal cancer or an advanced adenomatous polyp. Remember, the advanced adenomas are people who have a polyp that's 1 centimeter or greater, or has concerning histology or pathology under the microscope. So if you have a first-degree relative, a parent or sibling with colorectal cancer or an advanced adenoma that developed in this first-degree relative at age 60 or younger, or if you have 2 first-degree relatives at any age, it's recommended to start colon cancer screening at age 40. Or if one of your relatives happened to be 45, we would then start 10 years younger. We would start at age 35. And this gets repeated every 5 years. And the best test to use in this, given this history, is a colonoscopy. If you have a first-degree relative with colon cancer and advanced adenoma at over age 60, or if you have 2 second-degree relatives, 2 grandparents, for example, with colorectal cancer and advanced adenoma, then we begin at age 40, but repeat the colonoscopy every 10 years. And there are some rare hereditary syndromes that are associated with colon polyps and colon cancer. One is called Lynch syndrome, one is called familial adenomatous polyposis syndrome. And as you can see, these patients are at much higher risk for colon polyps and colon cancer. And so we start screening at a very young age with colonoscopy. So often patients say, I feel fine. Why don't I wait for symptoms to develop rather than have a colonoscopy now? Well, as I mentioned earlier, precancerous polyps often don't cause any symptoms, and removing them can prevent colon cancer. In addition, as Dr. Blaskowski mentioned, early colorectal cancer often doesn't cause any symptoms, and we can detect colon cancer at an early stage. Then we often, there's a greater chance for curing those patients and improving survival. And there may also be more treatment options when colorectal cancer is diagnosed at an early stage. So getting things detected at an earlier stage certainly is beneficial. So should I wait until I get symptoms to get checked for colon cancer? I hope you realize the answer there is no. We want patients to get screened, and screening basically is getting checked even when you don't have symptoms. And please don't hesitate to talk to your healthcare team about symptoms that you may have, regardless of how old you are, even symptoms that are hard to discuss. So blood in the stool, if you have changes in bowel habits, change in the shape or size of stool, if there's pain in the rectal area, abdominal pain, or if you have unexplained weight loss or unexplained or new anemia, symptoms that Dr. Blaskowski highlighted as well, please talk to your healthcare provider about that to determine whether or not you should have further evaluation. So what are some of the screening tests that are available? And I saw a couple of questions in the Q&A already about where certain tests fit in. So this diagram shows you many of the tests that we have available: a traditional optical colonoscopy, stool tests, a fecal immunochemical based test or a fecal occult blood test, a stool DNA test. The most widely available now is Cologuard, a flexible sigmoidoscopy, which is essentially an abbreviated colonoscopy where we're only looking at the lower part of the colon, or CT colonography. This is a study where you have a CT scan and they actually can look at the colon and determine if there's any polyps there. Of all of these tests, the only test that can completely remove polyps if they're found is colonoscopy. The stool-based test, the fecal immunochemical-based test, and the fecal occult blood test for blood in the stool, microscopic amounts of blood in the stool. So a stool sample is obtained and it's tested to see if there's blood. The problem with the fecal occult blood test, which is an older test, is that it's not specific for human blood. So if you happen to have had some red meat the night before this test, it could be falsely positive. A fecal immunochemical based test, a FIT test, is much more sensitive for human blood. And so for stool tests, you have to bring in a stool sample. And as this cartoon shows, this healthcare provider this is not quite the stool sample we had in mind. But there are a lot of choices. And as we always say, the best test is the one that gets done. So any test, if you're going to have anything, have something and not nothing. So here are the different screening options for colon cancer and some of the pros and cons here, and I'll highlight some of them. Colonoscopy is in general simple and safe, can be done on an outpatient basis. Pros are we can remove polyps and see the whole colon. The cons, there are risks that I'll talk about in a moment, and there are dietary restrictions. We like patients to be on a low residue diet and a clear liquid diet the day before, a low residue diet for a few days before, and then you need to take a potent laxative to clean out the colon. A stool DNA test for abnormal DNA in the stool. So colon cancers generally can sometimes bleed microscopically or shed cells, and we can detect the DNA from those cells in the stool. This test requires no prep or dietary restrictions and has greater accuracy, as I'll show you, to FIT. But it's a little bit more expensive and not all insurers cover it. And again, if you have a positive test, you'll need a colonoscopy for further evaluation. Same thing with the FIT test. If you have a positive test, you'll need to have a colonoscopy. Again, this fecal occult blood test, I mentioned some of the limitations there and some of the limitations of flexible sigmoidoscopy, where we're only looking at part of the colon, not the entire colon. Virtual colonoscopy or CT colonography uses a CT scan, so there's x-rays, and there's no sedation here, but it is expensive and it's not covered by all insurance carriers. And if you have a positive test here, you'll again need to do a second prep on another day to have a colonoscopy done. And this is important that I'll highlight what is the sensitivity of these tests. So as you'll see here, the ability to detect colon cancer by the stool-based test FIT or the stool DNA test is pretty good. But when it comes to detecting those precancerous adenomas, the precancerous polyps, the stool tests definitely fall short of colonoscopy or CT imaging of the colon. So you need to be aware that if you have a negative FIT test or negative DNA test of the stool, that there is still a substantial possibility that a precancerous polyp may still be in the colon. So some of the other risks for stool-based tests is the accuracy in detecting precancerous polyps, as I just mentioned, and sometimes insurance coverage for stool DNA-based tests. Colonoscopy risks, there's risks of you have to take a prep, there is sedation, there's risk to sedation, although the risks are fairly low. And the risks of perforation of the colon are also very rare. So perforation is a hole in the colon, happens in 0.01% to 0.3% of cases, or bleeding, 0.1 to 0.6% of cases. So these are quite rare, but we always let people know about it. And there was a question in the Q&A about risk in somebody who has mechanical heart valves and is on a blood thinner. We do colonoscopy, and it's very safe to do colonoscopy in patients who are on a blood thinner. We typically have that stopped, and there's a process of bridging anticoagulation to make the procedure safe. And so in general, it's something that we do fairly frequently in patients who have other medical risks. With CT colonography, you still need to take a bowel prep. Air is insufflated into the colon to allow the radiologist to see things better. And obviously this requires radiation, and I mentioned some of the insurance coverage issues. So basically with colon cancer screening, there's a one-step or two-step process. I've mentioned the two-step process, meaning if you get a stool-based test, you need to have a colonoscopy for further follow-up if the test is positive. With colonoscopy, it's a one-step test. We do a colonoscopy. If we see polyps, we take them out and would recommend a screening interval depending on what we see. And so the frequency of these tests, colonoscopy is done every 10 years and a FIT test every 1 year. Other options, the stool DNA test is recommended every 3 years, and a CT colonography every 5 years. So please get screened. March, as we've mentioned, is Colorectal Cancer Awareness Month. And as I said before, the best test is the test that gets done. So thank you very much for your attention, and I will hand it over to Dr. Francone.
Great job, Larry. Thanks, Lawrence. Thanks so much. And I'm going to share my screen. And is that presentation view?
Yes, you're good.
Great. So Lawrence, that was a great talk. And Dr. Blaskowski, it's a pleasure to be here with my colleagues. And I consider myself very lucky to work with these individuals who are experts in their field, and we're able to provide great care for our patients, especially for a topic such as colorectal cancer, which is near and dear to my heart, having family members experience this in our family. So I'm going to be talking about surgical approaches to colorectal cancer. And we obviously have different types of interventions that we can perform. As you already heard, that prevention is the best way in removing polyps early. And even when polyps are really large, we can certainly do things before we get to surgery. But for the most part, surgery can provide a cure for colorectal cancer if we catch it early enough. And when surgery is not enough, we can oftentimes help it out with chemotherapy or radiation therapy. And Dr. Hong's going to go over that with you, as well as some potential measures in regards to when it spreads beyond the colon into the liver and other organs such as the lung. So Dr. Bailon showed you nice pictures of polyps and how we can take them out with snares, but sometimes we get these large, giant polyps, and we often encounter these on your first colonoscopy. Maybe it was slightly delayed, or maybe it wasn't. And these things can be very flat and go over certain folds. And Dr. Bailon and I and his colleagues will look at this and decide whether or not this is amenable to being removed with a regular colonoscopy. And oftentimes we can do something called EMR, or endoscopic mucosal resection, where we remove this polyp in multiple pieces. The issue with that is that this can lead to higher recurrence rates. It can range anywhere between 10 to 40%, and this can depend on the location of the polyp, the size of the polyp, even the endoscopist. And so there's a decision to be made of whether or not we should attempt to do this. And if you do, then you're potentially looking at frequent colonoscopies, maybe in 6 months to a year, going back, looking at the scar, making sure that there's no residual polyp there, and then determining when to do another colonoscopy. Or you can choose to go on for surgical resection. And that's really historically what has happened in the past for these large polyps. And even to this day, the majority of these polyps will get sent on for surgical consideration. And that means that that means that you're going to get a piece of your colon removed, and we're going to put you back together. And that obviously comes with increased risks when you compare it to colonoscopy, such as bleeding and infection. We have to make either a large incision or even more so like a small incision. So perhaps there's some intermediary step that we can do before we get to surgical resection, and that's endoscopic submucosal dissection. This is supposed to be a video, but it's not playing. But essentially what this is an advanced endoluminal surgery in which the colonoscope can use a small endo knife, which can remove the entire polyp in one piece. And so you're not removing it in pieces. And this really was heralded by the Japanese and with extensive training in stomach cancer. It's a really challenging technique to do in the colon. It requires experience. There's a higher risk for perforation, and certainly does take longer than a routine colonoscopy. But overall, you can remove this polyp in one piece, and your recurrence rates will go down equivalent to that of a normal polypectomy. There's plenty of literature out there with over 30 comparative studies. The majority of them performed in Japan, which has the largest experience, and really does show that endoscopic submucosal dissection can be performed with an en bloc resection, and that lowers your recurrence rates of having these polyps come back, and you can potentially avoid surgery. It does get accompanied by a high perforation rate. We do perform these in the operating room, and Dr. Bailon has partners, interventional gastroenterologists that can perform this, as well as ourselves in colorectal surgery. And this is comparable outcomes in regards to complications such as bleeding. But not all polyps or large polyps are going to be amenable to endoscopic submucosal dissection. Sometimes the location, if it's located on the right side, Dr. Bailon showed you the anatomy of the small bowel going into the large intestine. Oftentimes these are difficult locations. Or if these polyps have already been attempted to be removed with multiple resections or multiple pieces, then the polyp gets scarred down, and then really ESD is not really an option, and then we go straight to surgery. So what happens if you do have an invasive cancer and Dr. Bailon notifies you and your path comes back? Well, typically, as Dr. Blaskowski mentioned, then if we can do surgery first, then that's typically what we'll do. You obviously are going to go through staging, and that's all the diagnostic imaging that was discussed in the first talk in regards to trying to understand the cancer that you have. What is the extent of the disease? Is this really still within the colon? Has it moved on to the lymph nodes? Or has this moved on to other organs such as the liver and the lungs, which is much harder to treat and understand and even control? When you present for surgical consideration, we take lots of things into consideration, especially the size, the location of where the tumor is located, as well as patient factors. So we look at your health, your body habitus, your quality of life, what you're doing, your performance status, what we think your quality of life will be like after surgery. When we look at the colon and the rectum, again, what we take out will depend on where the tumor is located. If you look at the diagram here, cancer is located on the right. Typically, we have the right side removed, and then we take the small bowel and we'll put it back to the colon. And so we call that restoring intestinal continuity. So you'll move things through just like you would normally. We really don't see a change in a patient's quality of life or bowel movements or bowel habits until we take the majority of the colon out and we bring the small intestine all the way down to the rectum. And we typically, this is typically not common. Just to kind of reiterate what Dr. Blaskowski was saying and Dr. Bailon, is that the earlier the better. When we encounter tumors that are resectable, this can potentially provide cure, and those patients have better overall survival rates. This is a study in 2018 by Sloan Kettering, and really looking at patients with liver and lung metastases. And the first line of those patients who have non-metastatic colorectal cancer, they haven't metastasized to any other organ. And typically these are resected and they have the best outcome. When you start looking at cancers that start to spread elsewhere, our survival rate starts to decrease. So earlier is better. We often use colon cancer and colorectal cancer interchangeably, and it's really important to try to distinguish between the two. Colon cancers and rectal cancers are treated very differently. When we look at colon cancers, these tumors are located within the colon, all the way up from the right, the transverse, the sigmoid, down to the upper rectum. And these are different than rectal cancers because they sit in this peritoneal cavity with the small bowel. And it's not so much free, but there's really very low risk for invading into other structures. And they have to get to a really big size in order to do that. So with that being said, they have a much less potential for leaving cancer cells behind. They're more amenable to surgery. And you even have a less chance of needing like the bag or the permanent colostomy that some patients are so afraid of getting when they come into my office. For colon cancers, because this sits in the peritoneal cavity in the abdomen, we oftentimes can employ surgery first, and that's the mainstay in regards to trying to lower local growth and spread and preventing this from spreading to elsewhere in the body. And then based on the pathology and the histology, when we look under a microscope, we can see if lymph nodes are involved, and then determine if we need to control the cancer at the body level or the systemic level, and that's where chemotherapy comes in play in regards to colon cancer. In the rectum, this is much different. This is the end of the colon. This is where the colon ends and the rectum begins, and down to the level of the anus. And this is really the functional part of your colon where it's a reservoir, it's a storage unit. If you want to go to the movies and make it through a 3-hour Batman movie, as we're going to attempt on this Friday for my son's birthday, then you're really going to need a good rectum because that's a long movie, right? So your rectum is that main organ that's going to help you do that. When we remove that organ, then that changes your quality of life and has a huge impact on some of our patients. This sits in the bony pelvis, so it is easy access to other structures. So tumors that develop down here can really have easy access and develop early, and they can become more technically challenging to remove. And when they become more technically challenging to remove, then we have a higher chance for this cancer leaving cancer cells behind and potentially having a failure of our surgery, or even what we more commonly call local recurrence. And so these things all come into play when we're deciding, what to do for patients with rectal cancer, and highlights the importance of preoperative staging. And Dr. Blaskowski mentioned, we oftentimes will get an MRI to help us decide what's going on before we do anything or before we make any decisions. When we talk about rectal cancer, it's really hard to generalize patients into early and locally advanced and determine and try to be more cookbook like the colon. Oftentimes go get surgery plus or minus chemotherapy. Rectal cancer is very much tailored to the individual. Typically for early stage rectal tumors, we may go for surgery first. And for more advanced tumors, we oftentimes very much so will go for treatment first. And Dr. Hahn will go more into detail on this. But that chemotherapy and radiation therapy, or a combination of the two, will help shrink the tumor, downstage it, and then we can get on for surgery. As I mentioned before, rectal cancer is very much tailored, but it wasn't always that way. In 1908, over 100 years ago, everybody ended up getting their rectum and anus removed and ended up with a permanent colostomy. And that really didn't change for over 40 years. The results always demonstrated that the survival rates and the recurrence rates were much higher when compared to colon cancer, and for the obvious reasons that I was telling you about. But we've come a long way in regards to the treatment of rectal cancer. And this is very much a multidisciplinary approach. You don't show up to a surgeon's office and say, I'm going to cut this out. This requires all the participants in the panelists that you're seeing and hearing, talking to tonight, to make a decision for our patients. It's no longer simply just remove the rectum and get a permanent bag. We have specific staging methodologies, specialized pathologists that focus on GI oncology. We have a whole range of surgical options, such as sphincter saving surgeries or sparing surgeries. We can do local excision, and even sometimes no surgery at all. And Dr. Hong is going to talk to you more about that as well. When we do have to do surgery in the colon or in the rectum, historically we've done these with large incisions. The majority of surgeries that we do, especially at MGH and Newton-Wellesley, are now performed minimally invasive. Most people think about laparoscopy when we mentioned minimally invasive surgery, but now that's more of an umbrella statement for both laparoscopy as well as robotic surgery. Laparoscopy is when we make small incisions and we distend the bowel and distend the bowel or insufflate with CO2 or gas, and that gives us room to work. With laparoscopy, the surgeon's holding the instruments and you need a good partner or an assistant to help hold the other instruments and move cameras where you want to. With robotic surgery, the robot is really actually holding the instruments, and then the surgeon is allowed to control all four arms without really having to tell an assistant what to do. And we'll talk about that more in detail. When we talk about sphincter sparing surgery, we're talking more about surgery for the rectum. As I mentioned before, historically, most patients went on to get a permanent bag. Now, when we look at tumors, even when they're really low, so this is, say this is like the distal rectum here, and even as we go down towards the sphincter complex, and the sphincter complex is what gives a patient or a person the ability to hold stool in voluntarily as well as involuntarily. When we start to get close to that sphincter, that's going to affect our function, our ability to control, which affects our quality of life. As we get lower, we can still spare some of the sphincter where we give you a good quality of life, but at some point, this tumor may be located into a point where we just don't think that the quality of life is worth restoring intestinal continuity. If we do feel like we can restore that continuity, then we can take that rectum out, and just like we would in the colon, we'll bring a part of the other part of the colon down and re-anastomose it to the anus. And this typically does require a temporary bag to protect that, just like any plumbing. We want to make sure there's no leaks, and then eventually that other temporary stoma gets reversed. There are certain things that we can do to help improve our sphincter sparing rates, and part of that is what Dr. Blaskowski and Dr. Hong do with pre-treatment with chemo and radiotherapy, as well as going to a high volume cancer center or rectal cancer surgeon specialist that has a good experience in this, such as what we have at MGH and Newton-Wellesley. So some people may ask, why robotics? Well, this certainly, I went into it just a little bit in regards to like the autonomy. This allows me to have 4 arms versus just 2. This allows better access, especially for rectal cancers in the pelvis, better visualization. The camera is very stable. We have superior traction, counter traction. These are principles that are essential for good surgery. And the enhanced ability to suture. And perhaps sitting down for the case may be a little bit better for my ergonomics and health. Again, this is supposed to show you a video in regards to the suturing, and you can see here, these are the wrists of the robot, and we're able to suture in the pelvis, down deep into the pelvis, sewing our connections or over sewing them. And this is something that's really just cannot be done laparoscopic. If you look to the left, this is an older version of the robot where you can see the ports entering into the belly, and the robot is holding the ports in order to be utilized. At Newton-Wellesley, we're one of the fastest growing robotics programs. We started this 4 years ago with 1 robot, and we've done over 600 colorectal cases, and our second robot just arrived today. And we've had good colorectal outcomes in regards to, 1, avoiding stomas, as well as performing colorectal sphincter sparing surgeries, and be able to, despite the body habitus or the patients, be able to provide them with minimally invasive techniques, which is not seen equivalently throughout the whole country. So we really have evolved colorectal surgery and how we approach colorectal cancer from open surgery, where we have large incisions, a broad application to any part of the body, but longer hospital stays and increased risk for comorbidities and complications. Minimally invasive surgery, whether it be laparoscopic or robotic, this is really continuing to evolve. Highly skilled surgeons are required to do this, but they provide reduced hospital stay as well as complications and adverse events. And the next step is really natural orifice surgery or NOTES, where we can perform some of these surgeries without incisions. We can do them through the colon or the stomach and then pull out these specimens through that. And we start to do that for benign cases now and have not moved towards oncologic cases, but it's certainly in the future. But more interestingly enough, one of the next steps has been to potentially avoid surgery altogether. And in rectal cancer, because our chemotherapy and radiation regimens are working so well there are a very small select few patients where we can potentially offer them a watch and wait program where we can spare their rectum. And this really brings us to the point of organ preservation. Lots of factors go into organ preservation and whether or not you're a good candidate: quality of life, potential for oncologic cure, sphincter sparing or sphincter preservation, patient tumor factors, and probably the most important, patient preferences. What surgery may provide, what is important to you, and what are your risks, and what are the risks with your cancer. Especially with rectal cancer and how we tailor this to the individual. Sometimes for early stage cancers, doing a big operation just seems a little bit much. And perhaps for some patients, very select, maybe less is more. For early stage rectal cancers, we see this. For even large rectal polyps. Large rectal polyps in the rectum, we have this ability and access to the rectum that we potentially can take them out, and even for early cancers, cure them. So this is called transanal endoscopic microsurgery. And historically, we used to do everything through the anus, which is very poor access. We can't see. It's a very narrow column. But this instrument provides basically laparoscopy or minimally invasive surgery through the anus. So everything gets magnified, improves our visualization as a rigid platform, and we're able to do our cookie cut these lesions out. You can see here, here's the camera, here's the lesion, and then we take the whole wall of the rectum. So this is very good for large rectal polyps. This is also utilized for early stage cancers or even locally advanced cancers in patients who are not good candidates for advanced surgery. When we talk about more advanced rectal tumors or rectal cancers, local excision is not an option. But perhaps we have other techniques such as chemoradiotherapy, which can help downsize or even perhaps shrink the tumor down to just a simple scar. And that's where Dr. Hong comes in. He's going to talk to you more about these non-operative techniques and even the organ preservation in its purest form. So at that point, thanks very much for your time, and I'll transition to Dr. Hong.
Thank you, Todd, for that great talk. Kimberly's going to be pulling up my slides now. Good evening, everybody, and thank you for joining in to listen to this talk on colorectal cancer. Next slide, please. When we think about improving cure rates for rectal cancer, what we're really talking about is keeping the cancer from coming back after surgery. So even with surgery, there's always a risk that the cancer can come back either at the place that it started or elsewhere in the body. This is referred to as local recurrence and distant recurrence. Next slide. So to put the problem in a little bit more granular detail, as Dr. Francone was discussing, colon cancer is different from rectal cancer fundamentally because of the function of the rectum as opposed to the colon. But if we think broadly about colon cancer, if a patient were found to have positive nose, as Dr. Blaskowski indicated, they'd be given chemotherapy, and that could dramatically reduce the risk of the cancer coming back elsewhere in the body. However, that patient would not need to see me as a radiation oncologist, because with radiation therapy, I'm simply aiming radiation directly at the area of the tumor to prevent what we call local relapse, and the rate of local relapse for colon cancer is very low. Next slide. So why is rectal cancer different from colon cancer? The reason is that the local recurrence rates are much higher and can really affect quality of life, as Dr. Francone mentioned. And the reason for this is primarily related to location. The pelvis is small, it's hard to cut out the cancer cleanly, and as Dr. Francone just discussed, it's a much more difficult operation. Next slide. The way that we try to reduce the risk of local recurrence is to use radiation. Again, radiation is the use of high energy X-rays that are focused at the area of the tumor to kill cancer cells. So the first lesson we learned is that we should be using radiation. And the second lesson that we learned is it's better to give the radiation before the surgery than after the surgery. And I'm going to show you why. Next slide. So this is some of the data that suggests that radiation improves local recurrence. This was a study done by the Dutch rectal group, where patients were evaluated with operable rectal cancer, and they underwent what is considered the sort of state-of-the-art cancer operation called a total mesorectal excision. And these were very well-trained surgeons, and half the patients were randomized to get radiation beforehand, and half the patients were randomized to surgery alone. Next slide. And what you can see is that the radiation dramatically decreased the risk of local recurrence. LR2 means local recurrence at 2 years, by a relative benefit of approximately 75%. At this early time point, an absolute benefit of about 6%, and that was statistically significant. Next slide. We also know that radiation is better to get before an operation rather than after an operation. This is the risk of local recurrence in a randomized trial done in Germany, where patients were randomized to get the radiation before the operation or after the operation. And what you can see is that the local recurrence risk was half with preoperative radiation, 6%, versus 13% with postoperative chemoradiation. Next slide. Not only that, it's easier to get radiation before the operation. If you look here at what's in the box here, at what percentage of patients received the full dose of radiation or chemotherapy, you can see that 90% of patients receiving their chemoradiation before the operation were able to complete therapy, as opposed to only half the patients who were randomized to get the treatment after the operation. In other words, better compliance with preoperative therapy. Next slide. So I think that, as you can see here, it's important to use radiation to decrease the risk of local recurrence, and that before the operation is better than after the operation. Next slide. But what about distant recurrence, or this risk of spread? One of the risks of colon cancer and rectal cancer is that the cancer can spread to other areas, most commonly to the liver, the lungs, or elsewhere in the belly cavity. What we've learned in rectal cancer is that chemotherapy can decrease the risk of distant recurrence. More intensive chemotherapy for rectal cancer may be better, and that chemotherapy is also better tolerated before the operation. Next slide. Here's one example of chemotherapy improving cure rates. This is a study from Korea where they evaluated patients who received chemoradiation followed by surgery. And if they still had what we call high-risk disease, meaning they still had advanced primary tumors or node-positive disease in spite of receiving radiation beforehand, they were randomized to receive single-agent chemotherapy versus multi-agent chemotherapy. Next slide. And what you can see here is getting the more aggressive chemotherapy did improve the risk of the cancer coming back. It decreased the risk of the cancer coming back at 3 years substantially. Next slide. And this led to a difference in the percentage of patients who are alive at 3 and 5 years. And this was also statistically significant. Next slide. So now that we've established that chemotherapy, and especially multi-agent chemotherapy, can improve the risk of the cancer coming back elsewhere in the body given after the surgery, what about the same idea about giving chemotherapy before the surgery? Perhaps the chemotherapy would be better tolerated if we gave the chemotherapy and the radiation all before the operation. And this is what's referred to as total neoadjuvant therapy. Total meaning everything, all the chemotherapy and radiation. Neo meaning before the operation. Adjuvant meaning to help the outcomes from the operation. So total neoadjuvant therapy. When Memorial Sloan Kettering evaluated total neoadjuvant therapy compared to the standard way that we do things, which was chemoradiation surgery and then chemotherapy, they found that by giving chemotherapy before the operation, there was, on average, was greater dose intensity, so to speak, fewer dose reductions, and the patients were more likely to complete all their treatment. Next slide. So with the concept that we can give the chemotherapy before the operation, the next question that was asked was maybe we can give even more intensive chemotherapy. So the multi-agent chemotherapy that I was talking about before was FOLFOX, which is a combination of 2 chemotherapy agents, 5-fluorouracil and oxaliplatin. But there is another regimen that's 3 chemotherapy agents all given at the same time called FOLFIRINOX, and that's 5-FU irinotecan and oxaliplatin. This transformed our treatment of pancreatic cancer with a substantial improvement in response rates and cure rates. And additionally, in metastatic colon cancer or stage 4 colon cancer, patients live longer when they get the 3 drugs as opposed to the 2 drugs. So this group from France asked a very rational question. Geez, if it's easier to give chemotherapy beforehand, maybe we can get away with giving even more intensive chemotherapy, and that will make things better. Next slide. So this study randomized patients to the conventional way of doing things with chemoradiation followed by surgery, followed by chemotherapy, versus 3 months of this intensive chemotherapy followed by chemoradiation and surgery. Next slide. And what they found is that there was a dramatic improvement in response rate. I'll draw your attention to the line at the bottom that says YPT0N0. What that means, that nomenclature refers to as after receiving the treatment before the operation, there was no cancer left, either in the tumor or in the nodes. And you can see that the likelihood of complete eradication with total neoadjuvant therapy with FOLFIRINOX was 28% as opposed to only 12% with conventional chemoradiation. Next slide. Not only that, this translated into a substantial improvement in cure rate, so that we were able to improve the likelihood of eradicating the tumor, and we were able to improve the likelihood of patients remaining disease-free with the cancer never coming back. So this represents a really big change in the way we think about treatment, and really is a big leap forward in terms of how likely we are to cure patients. And as Dr. Francone said, is it even now possible to avoid surgery and enjoy these substantially higher cure rates? Next slide. So again, to summarize the distant recurrence problem, we know that chemotherapy can decrease the risk of distant recurrence. More intensive chemotherapy does seem to be better, and chemo is also tolerated better before the operation as opposed to after the operation. Next slide. So the question is, does everybody need an operation? And this is a study called OPRA that was done at Memorial Sloan Kettering, where patients were evaluated after total neoadjuvant therapy and for the feasibility of not having to have an operation. And the numbers that you can see are as follows. Almost half the patients will have what we call a clinical complete response. What that means is that when Dr. Francone looks after Dr. and I are done with our treatments, we don't see anything. We don't see any evidence of cancer left. And when that happens, almost 80% of patients will be able to maintain having their rectum at 3 years and beyond. Even if the cancer looks like it's pretty much gone, what was surprising to me is that, which occurs in about a third of patients, and that's NCR, near complete response, it turns out that almost half the patients are actually able to keep their rectum at 3 years. If you have an incomplete complete response, meaning Dr. Francone can pretty obviously see the cancer, then it is very unlikely you'll be able to keep your rectum, and you really should move forward with surgery. Next slide. So in closing, what I would say is that the cure rates from rectal cancer are higher than ever. And typically, the way we are managing patients now is we are treating with chemotherapy followed by chemoradiation. And now we can consider no surgery in select patients. Next slide. This is a study that we're going to be opening this year at MGH and Newton-Wellesley Hospital. And what we're trying to do is leverage some exciting new technology called circulating tumor DNA, or ctDNA, where what ctDNA represents is cancers will shed fragments of abnormal DNA into the blood that is detectable. And there's data, including from our research group, that suggests that patients who clear their ctDNA are much more likely to enjoy a complete response from their treatments. And what we're looking to do is test the performance of the latest generation of this assay to see how well it predicts for either clinical complete response or pathologic complete response. Next slide. Thank you very much for your time. And at this point, I'd like to turn it back to Monique to answer any questions.
Great. Thank you, Dr. Blaskowski, Dr. Bailon, Dr. Francone, and Dr. Hong for those great presentations and encouraging news in terms of the colon screening and outcomes for treatment. We now invite all the presenters to start their video and join us for the Q&A. I know that we've gone a little bit extra on time here with the great presentations, and so Dr. Bailon's actually been able to answer some questions in the Q&A. We also encourage you as audience members to continue to put in questions, and we'll sort of open those up now so that we can answer the rest of them that are in there. So let's see. I want to just go in. I think there's a great comment in there that the content is excellent. And there was a question that I think a patient had about the mechanical heart valve. I believe that actually you had answered that during your presentation, Dr. Bailon.
Yeah.
And
Yeah, I think, I mean, maybe I'll just expand on that.
Sure.
If it's okay. You know, we always weigh the risks and benefits of any procedure, be it a colonoscopy, be it surgery, with one's underlying other medical issues, be it heart-related, lung-related, or whatever it may be. And so it's always a conversation with your healthcare provider about what is the safest way to screen for colon cancer and whether or not a colonoscopy should be done. And for the most part, however, we are able to do colonoscopy on patients who do have other medical issues, patients who are on anticoagulation, blood thinners. We are able to safely remove polyps in that situation as well. It just takes a little bit more scheduling, a little more preparation, and making sure that the procedure is done safely. And so we are able to do that. So I think it's always a conversation about the risks and benefits that you'd have with your healthcare provider.
great, thank you. I think that we saw a couple times the question just regarding when would you consider, or what age would you consider for doctors saying that colonoscopy screening is no longer needed? Maybe we can
Right.
share that answer.
Right, yeah. So I'd expand on that, and some of what I responded to in the Q&A is, you know, it's suggested that by national guidelines that we would stop routine colon cancer screening at age 75. But I would couch that in saying that if there is somebody who has a very strong family history of colon cancer, if somebody's had adenomatous colon polyps in the past, if somebody has any symptoms, certainly, that colonoscopy is safe at older ages, the risk may be greater in patients over 80 when it comes to risks of sedation and the prep and risks potentially of perforation of the colon, which is still quite rare, but it's really a conversation. So I usually ask patients, if we were to find a cancer in the colon, would you get treated? Meaning, based on your preference or based on your other medical conditions? Are you healthy enough to undergo treatment? And if the answer to those questions are yes, then the risks of colonoscopy or other procedures are likely outweighed by, the benefits are likely outweighed by those risks. So we usually go forward. So in patients who are over 75, I usually always have we typically will have a conversation with the primary care doctor or primary care provider about what the safest approach would be.
Great, thank you. One quick question, do polyps form in the small intestine as well? I think we focused a lot in terms of the large intestine.
Yeah, so polyps in the small intestine can develop, but it's very rare, very, very rare. And cancer of the small intestine is also very rare. There are only a few situations where we screen the small intestine or the stomach is in patients who have a hereditary cancer syndrome, like I alluded to, Lynch syndrome or familial adenomatous polyposis or other very rare hereditary syndromes that predispose one to polyps in the small intestine and potentially small intestinal cancer. But as far as the general population goes, we don't typically do screening of the small intestine.
Great. There were a couple of questions in terms of the at-home stool tests, but I think that we had that in the presentation. This will be available later, so I want to just check in on a couple of the other questions. One is, if your BMI is greater than a specific number, does that indicate a greater risk for colorectal cancer? So I think we had talked about higher BMI increasing your risk, but is there a targeted number there that's used?
So the targeted number that's been looked at is a BMI of 30 or more, which technically is the definition for obesity. I would say there's a lot of problems with the BMI in accurately determining risk for a variety of things, but it's sort of the best measure we have. And in epidemiologic studies, that's what has been associated with a greater relative risk for colon cancer is a BMI of 30 or more.
Great. And then one more here on the screening piece. So if one is having persistent diarrhea to varying degrees, why would a patient be referred to an ENT doc rather than seeing a gastroenterologist?
That I don't know. You would not, specifically for diarrhea, that's something that we see all the time, chronic diarrhea. And so not something that an ear, nose, and throat physician typically would get referred to. So something that is one of the most common referrals that we see in the GI clinic or GI offices.
Great. Let's see. And is there more of a danger of perforation of the colon with older patients, say in their 80s?
Yeah, there have been studies looking at that, and the risks are greater for patients who are over 80 for colonoscopy. I would argue that if the procedure is required because of symptoms or bleeding or what have you, that usually those risks we can mitigate and do the procedure quite safely without significant complications. Again, as I mentioned, if this is for routine screening, I always have the question to the patient and to the primary care provider is whether or not the patient is fit enough medically to undergo a procedure or to have treatment if a cancer were to be found.
Yeah, I agree, Lawrence. I think the big question with the age in colonoscopy or any procedure is that older patients, the geriatric population is a very mixed group. And they range from like a 60-year-old with multiple comorbidities to a 90-year-old that does push-ups and sit-ups every day and walks 4 miles.
Right.
And you said it best. If you are an individual who, if there is something wrong, you are going to seek treatment, then you should still get your colonoscopy screening, because you're eventually, and if you're going to come talk to me, the majority of who we operate these days are above the age of 75, and patients actually do quite well. When we do elective surgery, your outcomes, even in the geriatric population, are almost equivalent to those patients less than 50 years of age. And that goes for even those patients who have a couple of comorbidities or some decline in cognitive function, or even require some help at home in regards to activities of daily living. So you really have to take the individual into the consideration, and it really is just a phone call to Dr. Bailon or your primary care doctor to kind of help you make that decision. But if you're in that mindset of, I'm going to do something I want to know, or if you have a history, then you really should continue your screening and surveillance.
Yeah.
Great. Well, thank you all. We are at time. This concludes tonight's event. Please be on the lookout for an email, which will include a full recording of this presentation, as well as additional community resources. We thank you all again for joining us tonight, and we look forward to seeing you at a future Newton-Wellesley Hospital event. Thank you, everyone.
Thank you.
Thank you.
Good night, everybody.
Night.